tell you the secret later on. It's a great honor and pleasure to be talking to so many of you. For the doctors in the audience, like many of you, I also work in many parts of Sarawak. Work in Sarawak Hospital, in Kapit, in Uka. I think many of you haven't worked in the old Lau King Hospital and also in the Sibu, the new Sibu Hospital. I'm extremely happy because I'm also from Sarawak. Like your founder and chairman, and we studied in the same school to get together. So I'm actually happy to be part of this anytime, anywhere. Okay, thank you. So my talk today is on hypogonadism, a commonly missed condition. So this is the magazine, the Time magazine headlines some years ago, and it says here, if you can see, it is a $2 billion business. But this is actually on anabolic steroids. My talk today is not about anabolic steroids. My talk is to talk about testosterone in the role of men's health as a medical condition. We also will not be talking about the use of testosterone in endocrine conditions like pediatric patients, So it's basically on this topic of testosterone in men's health. Now, this talk is sponsored by Rego Basins. So most of my slides will be on this topic, but I think I won't take 45 minutes. So at the end, there will be time for us to discuss about anything else, about university, about education, about urology, about prostate, about BPH, about cancers of the urinary tract. That is my expertise. So back to this topic. These symptoms that is listed in the slide are very familiar to all of us. Fatigue, Today I don't feel fatigue when I walk in here because I'm so encouraged by the scene here today. Quite often we have fatigue, we have mood changes, and of course for me, as a urologist, my emphasis is on sexual function of men. Together with it is mood changes, like mood changes for females when they have menopause. But are these just the normal signs of aging? We all get old, right? I'm 68. I think most of you in this, I'm the oldest man in this audience, I think. Most of you will not face this, but for the doctors, you will face many of these patients. Many patients in Malaysia now are above the age of 65. So you may think that, well, all these things are part of normal aging, and as we get older, our hormone also decrease. But you must think carefully, is this drop in testosterone cannot be improved? Can it be optimized? And the answer is yes. As we grow older, every organ in the body will get smaller. Every item in the body, you know which item I refer to, except for the prostate gland. So the testosterone also drops. Okay, after the age of 30, you drop by 10%. But if this drop of testosterone affects your life and becomes symptomatic and it can be corrected, then it's something that we should be able to do. If something can be corrected safely, we should be able to do. So this is the topic that we are going to discuss this morning. What is this thing called testosterone deficiency syndrome, or other words called hypogonadism? It is a situation where we don't have enough testosterone for the body to function normally. Okay, so, and this is very common with comorbid conditions like diabetes, hypertension, hyperlipidemia, and obesity. The aim is not to give excessive testosterone, but to restore the testosterone to the normal level, Okay, bring the testosterone to the normal level. It's called testosterone replacement therapy. Okay, that's the concept of this testosterone for men's health. Now, you may ask, what is the local data like? My good friend in Subang Jaya Medical Center, I can see they got a booth here, and Dr. Tan Hui Meng is my good friend. We studied at MU together, and he did a survey many years ago, but I think it's still the same or worse. About 20% of men, when you test the testosterone, and if it is, they also have symptoms, it's about 19.1% of men have this condition called TDS. So it's quite a common condition. Usually the blood is taken in the morning, fasting sugars, fasting blood 7 to 11. But you know, in Malaysia, patients come any time of the day they like. So actually, I usually don't bother too much. Like many of the patients from Indonesia, from outstation, by the time they arrive in Kuching, they have taken the Colombine, the Sarawak, so it's okay. I think it's not so important. But what is important is that many of these patients have associated comorbidities. The heart, they cannot walk, they're obese, they are depressed, and they have this thing called metabolic syndrome. So this T is a factor in all these conditions, and it may be that you can correct the T, and many of these conditions will improve, or maybe even be taken off treatment. What about in Kuching, my own hospital? I've been teaching in UNIMAS since '95, so I have a quite academic inclination to the way I think. So I look at my patients way back in 2001, and on the average I see about 1,000 patients a year, and about 100 of them are patients with erectile dysfunction. And of this age group, you know, the age group is 28 to 75. So many of you fall into this age group. And the comorbidities are, many of them have hypertension, have diabetes, have psychological problems. Many of your patients you see have psychological problems. The underlying problem is psychological, and of course cardiac conditions. But 20% of them have got low testosterone. 20% of this group of ED patients have low testosterone. So if you just treat the ED, then it's insufficient. So this is the situation in Sarawak. Now, I'm a urologist, so I look at the men's health. So the important things for me are the things like the muscle strength, the bone strength, and also of course the sexual function. The sexual function of usually the male patients and not so much the female patients. Female patients, they go and see the gynecologist. So if you find that they have a low T, and you try to correct the T by whatever means, medication is only one way. Then they probably have a better quality of life, they have a better control of the diabetes, they have better weight control, they don't fall and fracture so easily, and their mood will improve. So the T is an important component of this total health care. But why don't patients and doctors alike think of this testosterone problem? Because most of them think, this is a survey done in the UK, right? In the UK, most of the patients themselves think that this T, I think never mind, the laser pointer, I think the battery is gone. It's the usual problem. So they think that it's a normal part of aging, normal part of aging. So that's why they don't think of it. And of course, as a doctor, as a doctor, we also think that, well, T is not so important. We think of their diabetes, their cholesterol, their kidney function, their heart function, things like that. Not yet. So usually in most meetings we control the slides from here, but today's meeting we can't. No, I want the pointer. It's okay, it's alright. I got one in my bag, but I think I can do it. So one of the cardinal symptoms of low testosterone is low libido. So if the man comes and tell you, oh, I'm not interested in whatever, including sex, then there's quite an early sign of testosterone deficiency. And of course, slowly they have poor erectile function. Sometimes patients will not tell you. They come with all kinds of complaints, itchiness in the groin, some swelling in the groin, some pain around the penis, but actually what they have is erectile dysfunction. I have a very high index of suspicion, especially if these patients have metabolic syndrome. They say that up to 52%, up to half of the men who have metabolic syndrome will have this condition of low testosterone. But of course, it may be multifactorial. And in one big survey of 24,000 men, they find that people with low testosterone have a higher mortality. In other words, if your testosterone is low, the chance of you dying for whatever cause is higher. So it's quite important that you try to correct your testosterone. I think it's quite similar to like, you've got a blood sugar of 20 running around, so after 20 years, it's not likely that you have kidney failure and die, quite likely you have kidney failure and die. So, what are the other symptoms? The other symptoms put in a graphical manner, especially for your patient to understand for low testosterone. So, in addition to the usual sexual problem, they have fatigue, they are depressed, and they cannot concentrate. They got mental fog. They have lost the muscle strength, and of course, I think we have seen this quite a lot, the truncal obesity. This is one of the questionnaires that I use called ADAM questionnaire, Androgen Deficiency in Aging Male questionnaire. And these are the 10 questions you ask them. And if any of these questions is positive, then it's likely they have testosterone deficiency. But of course, the symptoms are not specific. But if you have these symptoms and you have a low testosterone, then you're likely to have this condition called TDS. And mind you, this has been there for a long time. Year 2000, they come up with this ADAM score. Sometimes we think that sex is not important. We think sex is just part of having pleasure, intimacy. But actually, sex is extremely important for our general health, both for men and for women. For men and for women, for your mood swings, for your muscle, for your bone density, for your cardiovascular function. So it's not just a function of having sex with another person. I think sex is very important. We might like to say that it's not important. We're like, oh, sex is not important, so actually, testosterone, sex is a very important part of general health. Okay, so what is the biological definition of low testosterone? There are many definitions. This is the British Society of Sexual Medicine. They say the testosterone should be less than 8. Of course, there are different measurements. There are nanograms, there are nanomoles, and then they have the free T. But usually, I myself in my clinical practice, and most of the Malaysian urologists, we take 11. If it's less than 11, then it's likely they have a low testosterone. But what is more important, if you have a very high index of suspicion, this guy got ED, he got metabolic syndrome, and then his testosterone is on the low side, but it's still above 12. Then what you can do, you can have a trial of therapeutic trial, or you can look at his old testosterone. Maybe his testosterone previously was 20, and now it's 12. That means his testosterone has dropped. So you can have a trial of treatment if you like. But of course, basically, you just look at the normal range that's produced from your lab, either PAP, lab, or Quest. I don't do the free testosterone anymore because it's very expensive and you have to send it out. Then we talk about medication again. Medication. As a pharmacist, as a doctor, we all talk about medication all the time. So patients like to have a tablet. Take a tablet. So this is Andro from Hypogonadism. I used a lot of it when I was in GH Care. In fact, the National Family Planning Board, IPPK, they used to have a special deal, RM1 per tablet, per capsule. It's an oily capsule, and Androcap, Testocap. Then we have sublingual, then we have all kinds of creams, then we have injections, and we also have pellets. So if you have got friends in Australia, for example, they like to put this implant. This is an implant. They put it under the skin. It requires very small incision. The injections are quite painful, and there are different kinds of injections. But currently in Malaysia, because once they start the new drug concerns, now they have to register the drug. So now we don't have the oral form anymore. But it doesn't really matter because the oral form has got side effects on the liver and is very poorly absorbed. So what is available now in Malaysia is basically the transdermal gel and the intramuscular injection. Intramuscular injection, let me see whether I've got it. There are only two types. One is called testosterone, and the other one is Nebido. But the injection in Malaysia we have now is testosterone. In fact, it has been available for a long time, since I was a young houseman. So this is testosterone, and it's quite freely available in the government hospital. And the other one is Nebido. Nebido is the injection that lasts for 3 months. But the problem with injection is that you got a very high level immediately. I got one patient who had the testosterone injection in Indonesia, and he came the following day. His testosterone is 51 nanomoles per liter. So they have what is called a roller coaster phenomenon. So if you give the little boy testosterone, he becomes very active. He goes to school, he fight with people. If you give it to a patient, you go home and fight with the wife, or start looking for alternative activities. So this is the roller coaster effect. But it is quite effective. It's quite effective. So injection have this problem. Injection it lasts longer, lasts 1 month. So if you're on the testosterone, then you have to go for monthly injections. There's some children who go for monthly injection in the government hospital because Nebitor is not easily available. And then you got all these problems with injection site pain, and it's a very thick oil, so sometimes can cause embolism. So some patients, if you give the injection, then you have to observe them in the clinic for half an hour. Sometimes they got a cough and pulmonary oil embolism. You have to use a big needle to inject it. Whereas the gel, you apply it on the skin. And we apply in the morning because in the morning, like now, our testosterone is the highest. So you try to mimic the normal testosterone rhythm. So this is the androgel. They have a booth over there. I have one box in my bag if you want to try androgel. So you apply it in the morning, and this has definite. There's no question about the medication not being effective. There are many trials done. It affects improves your sexual function, of course, and also on the other parts of the function. And it works fast. It can rise up within 2 hours, and you reach a steady state for 2 days. So this one doesn't go through the stomach or the liver. From the skin, it goes straight to your bloodstream. So that's why it is. I think to me, it's a very good medication. So I requested for this drug way back in 2012, and it's approved by FDA. And it's a gel. It's easy to apply. You can maintain it in the body. It's proven because I have to justify why I asked for this medication since 2004, and it improved not only the testosterone functions, it also improved the metabolic function in terms of glycemic control, etc. And I last reviewed this in July this year. I have 122 men on this medication. The average age the patients are on is 45 to 86, with a mean age of 67. And many of my patients have been taking it for years, more than 5 years. The problem, of course, is the cost. There's a cost element to it. And of course, I work in normal hospital, which is 100% owned by the Sarawak state government. So I have no share at all in anything. To me, is the patient's interest. Patient interest number one. So most of my patients will end up buying the medication from pharmacists here and there. So I don't have the total control of exactly how good the medication is for some of the patients. There's lots of follow-up. So how do I apply this medication? Basically, you take the gel and you put it on the hairless skin in the morning after shower, and you have to leave it there for a few minutes for it to dry. And during that few minutes, you shouldn't allow your girlfriend or your little boy or little girl to touch because it's a male hormone. After 2 hours, you can shower and keep it. So we try not to pass it to other members of the family. So okay, it's quite easy to apply. But if some of the old men, they have difficulty even opening the sachet, it can be a slight problem. It maintains the level for 24 hours in the body. Okay, so it's a very effective medication, androgel. Maybe I go backwards to explain a little bit more. So there are some technical challenges to the gel. So yesterday I saw a patient. He's 80 plus. He's quite depressed. He's got metabolic syndrome. And he came back. I said, what happened to his testosterone? Is still very low, but 1 point something. Normally it's at least 11, so it's very, very low. So it's definitely a contributor to his depression and his poor control of his metabolic conditions. So he said he has difficulty applying it. Also difficult to get the daughter or the young Indonesian maid to apply on his body. So he opted for the injection. So they were lasting 3 months, but you have a roller coaster effect, you go up and down. So some patients who cannot apply the gel religiously every morning, then they may be more suitable for the injection therapy. But just remember the roller coaster effect. The other effect is that if you have high dose of testosterone, you will affect the testicle. So if you want to have a child, the testicle is like shut down, because they don't have to work so hard anymore. So they will have poor sperm count. So the 65-year-old Tato or Tansri who want to have a child with the third wife, then there will be a problem. So remember the fertility aspect. And the other aspect is that the testicle, when they don't work, like I don't walk, the testicle will atrophy. So the testicle go into atrophy. So they become dependent on the injection testosterone. So there's this major disadvantage. So I seldom use Nebido nowadays, except for men who find it challenging to apply the gel every day. Okay, so again I show you some more publications to show that this medication is effective. 5,000 our men or 5 years with a placebo arm. So actually there is no question that this medication is effective for the treatment of TDS. And they even have placebo control arms of 2,000 over men. So this medication is very well tested. And if you look at the sexual function actually improves, of course, with this therapy. But if it is multifactorial, you correct the T as well. You just don't give them a PD5 inhibitor. No? So patient with ED, you just throw them Viagra, 100 milligrams. They come back. Oh, not so good. Okay, never mind. You're supposed to try 8 tablets. So they try for another month. It's still not very effective. Then you have to correct the T. You have to correct the testosterone. So if you correct both, then the patient will have a much better erectile function. And of course, the sexual desire as well. So this is patient who is on this treatment. 2,601 patients who are on this treatment, and this is to study the cardiovascular data. There was a rumor that if you take this Viagra, testosterone, all this, you will die from heart attack. But again, this shows that it's not true. It's not true that testosterone on the supplementation dose, not the super high dose for the anabolic steroids. Those are different story. It's cardiovascular safe. In fact, I think it's cardiovascular protective. The other thing is, of course, we know that testosterone is important for the prostate. And men above the age of 60 almost always have some kind of urinary symptoms. So you were not so keen to give them testosterone. But this has been studied extensively by different groups, different parties, Americans, Europeans, and the conclusion is testosterone is not the cause of the prostate problem. Not the cause of the problem. But if you have a prostatic cancer, then it's probably better not to give the patient supplementation of testosterone, unless the patient really wants it, and he's very clear that his prostate cancer is going to progress irrespective of that testosterone. So I have men who got prostate cancer, who have low T, and they cannot function unless they have the T replaced. Then they're on the T. They are taking the T as well, despite having prostate cancer. So that's the important thing. But of course, you want to rule out a prostatic cancer before you start them on testosterone replacement therapy. So this is one of the conclusion slides that actually if you give testosterone, it significantly improves the sexual function, the other functions of the man, including the body mass, the bone density, and of course the mood as well. I have quite a few patients who was been diagnosed with depression, taking multiple drugs, and of course these antipsychotic drugs, I can tell you, we actually don't know how they work. Many of them, they just walk around like zombies, they cannot think. But if you remove some of these drugs and give them testosterone, I can tell you that many of them improve if when you have the testosterone replaced. So this is the Nebido. Nebido comes in a vial and is a very thick liquid. You must make sure you use the 21G needle, and you have to inject it slowly over 1 minute. It is quite a painful injection. You put it deep intramuscular. It is high dose. So in high dose, the side effects are more. So I have patients who have got high hematocrit up to 20 or 25. Then I have to refer to the physician or the hematologist to do a venesection. Otherwise, they can get a stroke from a high hematocrit. But whereas androgel doesn't have this problem of causing a high hematocrit. Thus, the use of androgel actually is extremely safe. This is the injection. Not many patients, maybe about, last time I used to have maybe every month, but now with androgel, I seldom use Nebido. Okay, so this is the study to show that if you take if you replace the testosterone, as well as giving them PD5 inhibitor like tadalafil, sildenafil, vardenafil, all these Viagra-like drugs, they actually improve your treatment of patients with ED, erectile dysfunction. And erectile dysfunction is very common. Most of your men above 65, when they see you, will have erectile dysfunction. They may not tell you straight away on the first visit. Okay, this is the idea of medications. But I think in life, for most patients, and I'm sure the PMG group will be going to this, dietary therapy, the diet, exercise. All these are important part of the overall management of the human being. What about side effects? I think it's not possible to have medication with no side effects. No side effects. If the patient asks me, I always tell them everything has side effects. The medication, the surgery, the endoscopy, the laser, the robot, whatever. And so this is one of my patients. He got very severe acne after he went on androgen therapy. So of course I had to stop it. This is one of the side effects. And of course, the other thing is the compliance. And the other big side effect nowadays is money. So they call it financial toxicity. Okay, financial toxicity is a big problem in Malaysia now, especially for private hospitals and for surgery. So it's very important that PMG goes in this affordable and accessible therapy. Very important. So this is how do you monitor the patients? Of course, first of all you must make sure that they don't have a prostate cancer, and then we monitor them on and off every 3, 6, 12 months. We check the baseline blood profile, including the PSA, and then we monitor them, say, every 6 months or 1 year. I actually don't really do a DEXA to measure the bone density. It's more like orthopedic thing, and actually many orthopedic surgeons are also interested in men's health. In fact, there's one in my hospital who not only do this hormonal thing, but also in stem cell. So there are some side effects of this therapy. Okay, so I give quite a lot of lectures to various groups of people, doctors, and especially medical students in the UNIMAS. And in the media, you hear this bullying, doctors committing suicide, students not doing well. So when I talk about the treatment of a human being, I think the first important thing is the happiness. So if the patient comes here to your clinic or to your pharmacy, you smile at the customer. Happiness is very important. So today I'm very happy because I come to PMG function and from Sarawak. Then the next thing is healthy. To be healthy, you must be healthy. As a doctor, healthy. So what are the big parameters? Blood pressure. Malaysia, blood pressure, glucose, terrible. Body weight, obesity is getting terrible. And then of course there are many other things I put on top there. Then exercise. I think most of us do far too few exercises, especially even the younger people. They spend their time on the computer, playing computer games, look at the monitor all the time. So I think exercise doesn't mean you must go to the gym membership. I think just walking is good enough. Sunlight, too much time we spend inside the room. Sunlight and exposure to nature. So this is actually personal sharing. This is my daughter. She is doing a PhD in neurology in London, neurology. She comes back, you can see she's very happy. And she's happy because she has got the 3 dogs that love her. And this is my house in Kuching, not my house in Sarawak. This house in Kuching, I grow fruits, I share my fruits with the birds, there's sunlight, and this is my family. My wife is a teacher for 34 years, so anybody from St. Mary's School, anywhere in Malaysia, she could have been her student. And my first son is a GP, my second son is doing a PhD with UNIMAS in medical education, and this is my daughter, she's doing a PhD in neurology. So it's a trend now for a lot of young people to carry on studying. But to me, to treat any condition, this is my sharing as a fellow doctor from Sarawak. To treat any condition, may not be a disease, that's a condition. You have to think of the pros and cons of what you propose, including the tests. Many doctors, many hospitals just order a battery of tests, so think of the pros and cons like doing a PSA. And what are the medications you give the patient, pros and cons, and surgery. Recently, I just read yesterday, there's an article to say that 50% of the surgery in most hospitals are not indicated at all. They don't need the surgery, they don't need the test. And then of course, before that, you have to think of the natural history. If I'm giving this medicine to the patient, how is it going to affect the natural history? Is the patient going to die from renal failure, going to die from heart attack? And of course, most important is prevention. you must talk about prevention at the end of your consultation or the treatment. There must be prevention in the plan somewhere. So if your patient has got low testosterone, very low, give them replacement therapy. But at the same time, they must go on to their diet, their exercise, and their other sectors in their life, including the family, of course, including the family. Family life is very important. I think if it's a broken family, it's big trouble. So this is my summary slide. This is my last slide. Okay, so T deficiency is clinically significant. Low T is underdiagnosed for many reasons, and even if it's diagnosed, it's undertreated also for many reasons. So I've got 10 minutes. So we've got time to discuss. So testosterone supplementation therapy, to the physiological range, not the high range like the bodybuilders, is safe. It's very safe. So if you got high dose, you got many other problems, cardiac problems, cancer problems, fertility problems. So the tea is probably best given in the morning as a gel. If the patient is compliant, if the patient cannot put the gel there, you think of other things like injections. Oral therapy at the moment not available in Malaysia anymore, but I think it's not a loss. The main side effect is the cost. I suspect it's probably about 10 ringgit per dose. Most people take one sachet. Some people may require 2 sachets because the absorption is poor. Children, you have to give it for children with small penis, micro penis. Sometimes they take a quarter of a sachet and apply it on the penis. So this must be treated as part of total human being wellness, not only patient wellness. Exercise, different kinds of exercise. We start with aerobic, then we have encourage weightlifting, sunlight, dietary. Sleep is very important. A lot of older people have problems with the sleep. So you think of sleep hygiene, how to improve their sleep. They must sleep at least 5 hours for the body to have sufficient rest. And the metabolic treatment. Smoking is the difficult one. My own father smoked until 90 years of age, so smoking is the difficult one. You have to handle it in care, because if the patient comes to your room and says, "You must stop smoking," I think we put the patient away. He won't come and see you anymore. So that kind of advice is to be a bit careful. Alcohol, I think is a way of life in Sarawak. so alcohol is the difficult one. And then the social economy. Social economy is quite important. Many of my Unimas medical students don't take the history of social economy, or you make a big diagnosis, this. But I said, how many children the patient has, and where are the children? Many of them cannot tell me, because if a patient in Kapi to Belaga, and the children are all working in Congo, so it's going to be a big challenge to send the patient to Kuching, for example, for the treatment of the prostate cancer. So social economy is quite important part for Sarawak, and I think PMG is probably going to be right to give sort of the best care which is affordable and accessible. Family, I've been working for 44 years, and now I have no regrets that you have to somehow along the history talk about the family. My wife said, "Why kepo?" I think family is very important, and finally spiritual concerns. You can do everything in life, but I think the patient will have to have a certain concept that we cannot change everything in life. Everybody will die. We have to face the end of life discussion when we treat a person. So spirituality is very important. It doesn't mean that you must be Christian, or you must be Buddhist, or you must be the Muslim. So if you go that way also, it can be wrong. Because different people got different idea about spirituality. But I think that's the important thing that you have to address when you treat the patient as a whole. So now 5 minutes. Okay. So this is my last slide. This is the Damai, so maybe next year we can go have a retreat in Damai. This is my email and my WhatsApp. You don't have to refer me any patient, but I'd be happy to continue discussions regarding urology. I can email this or WhatsApp this PowerPoint to you, so you can use it in your discussions with your patient. And I hope that I have given an idea of what is the sort of approach to the patient in the mess of all this huge amount of medications, robotics, lasers, how to manage a patient. And T, of course, is a central component of this management. Thank you so much. Okay, questions? I can send you the PowerPoint And there are a lot of references I can send to you as well, but I summarize it so that it's easy for you to digest, easy for you to think as a fellow doctor. And I work as a MO for a long time. I even do locum for many of my GP classmates when I was in university. Because in those days, our salary is 1,003. How can I fly to UK to do my exam if I don't do locum at night? Questions? Excellent. Where's Leonard? Leonard is here, okay. Leonard's supposed to fire me some questions. Okay, we got 5 more minutes.
Good morning, Professor. I just want to ask, is there any role for androgel in postmenopausal women? Because apparently in US, postmenopausal women also use testosterone and they feel better, they mood better, and also they feel more energetic after they use testosterone. Is there any role for androgel in postmenopausal women?
Okay, the answer is yes. The simple answer is yes. And it has been used for a long time by the gynecologist. But the dosage may be a bit different. Maybe you titrate. Okay, let's spend 1 minute on female sexual dysfunction. Female sexual dysfunction, okay. We don't have a female sexual dysfunction clinic in Malaysia, but when I was in Edinburgh, we have such a clinic run by the psychiatrists. So they break down the problems. The biggest problem of female sexual dysfunction clinic is no interest in sex, low libido. They're not interested. Somehow they're not interested. So you know, we always say that for the female, you just have to lie down, right? You do nothing, lie down. You can even go to sleep. But of course, it takes the pleasure out of the activity, take the pleasure out of the interaction. So that will be very good for low libido. And also, of course, it's good for bone, for hematocrit, if you have anemia, persistent anemia. So actually, there is beneficial effect of tea in women as well. But I'm not a specialist in the area. So tea is useful. So if you have a couple, the man come and say, oh, she has no interest in this thing. Every night she's tired. She got backache, this one, that one. So maybe a low dose of tea will do for her. But I don't know the exact science behind the normal range. So I think there's absolutely no harm in giving her one session every other day or half a session a day. Just share with the partner. Good answer, good question, excellent question. Another day we get somebody else to talk about female sexual dysfunction, how you treat female sexual dysfunction. Low interest. The other one is no orgasm. Actually, the female have got no orgasm throughout the whole life. Because the other things like dryness, pain, in treatment of female sexual dysfunction. In Malaysia, I tried to ask them to bring the wife, but then I realized that actually it's quite a sensitive thing. Because many of the male patients, their regular partner is not their wife. So there is a problem there as well. Okay, Leonard. Your job is to fire me some questions.
Hello. So I have a question for Professor. For the use of androgen gel, it's lasting 24 hours. So do they have to use every day, lifelong?
I try to avoid that kind of solution to the patient. You tell the patient you take this lifelong, patients won't be happy. And I prefer not to have anything lifelong. So they take it usually for 3 months. Because in normal hospital, many of the patients are state sponsored, they don't have to pay for it. So I give them a 3 month supply. So 50 milligram androgel OM times 3 months. When they come back in 3 months, we have the symptom review, and often I repeat the testosterone. In the meantime, I tell them this is supplementation. Your testis is producing the hormone. Your brain is activating the hormonal axis. So you must exercise. You must control your diet. You must go through your whatever, your family dynamics, whatever. So I don't intend it as lifelong. But many of my patients do take it for some time. And then if it's normalized, they can take off it. They can be off the treatment. So it's not meant as a lifelong thing, but if somehow they cannot correct the other factors, the testicle cannot produce enough testosterone, then probably it's taken lifelong, but at the end of it, then maybe he have other priorities as well, maybe run out of money, no money to buy the gel. There are some production by some pharmacists in PJ, which they actually prepare it, and they're the compounding pharmacists, but I'm not sure about how reliable is that in terms of absorption. So it's not, should not be a lifelong thing. I think even nowadays, I tend to challenge you that even diabetes or control of blood sugar need not be a lifelong treatment, If you correct the other factors, even high blood pressure, we used to think that, well, at least I used to think that high blood pressure and diabetes is a lifelong medication. No, I don't think so. If you correct the other factors, sometimes you can be off medication. But it doesn't mean you don't have diabetes. It doesn't mean you still have diabetes there, the metabolic problem is still there, but you don't need medication. Thank you, Leonard.
Thank you, Professor Clarence, for your expertise in
Time's up. I have to rush back to run my clinic now. Saturday is the clinic for private hospital is a busy one, so I hope I'll be in touch with some of you. Thank you.